Now, why not we combine these two technologies together to help us get the best benefit for our patients? And that is where this combined intervene trial comes in. And I'd like to share with you some of the insights, which will be published later on in the year. I expect either this year TCT or next year ESC. Stay tuned for this publishing this data. But I have a privilege to be involved directly in the clinical trial. So what we did here is actually we recruited patients with multivessel disease, more than 2 lesions and more than 50% stenosis. And one of the group is randomized into the FFR only guided group, where you have FFR less than 0.8, you proceed with PCI. If your FFR more than 0.8, you actually go for optimal medical therapy. Now, the interesting part is this. If you were randomized into the FFR plus OCT guided arm, then if your FFR is less than 0.5, well ahead, proceed. Yes, go for OCT guided PCI, do the best job possible. But if your FFR is more than 0.75, and I'm sure you know that the 0.75 is a more accurate predictor compared to 0.8. If it's more than 0.75, we then still proceed with an OCT to look for vulnerable plaque, being thin cap fibroatrioma, plaque rupture, unstable plaque, or you have more than 70% stenosis or plaque burden, and an MLA less than 2.5. If you meet these criteria, we still go ahead and do a OCT guided PCI. If not, we then go on with a optimal medical therapy. And these patients will follow up for 1 to 2 years after recruitment. So just to share with you a simple 2 cases, do not want to keep it long, we just want to keep it sweet and short. 2 cases that I've recruited in this clinical trial. So for this first case, it's a 59-year-old gentleman presented with acute inferior MI. He was given thrombolysis therapy in the peripheral hospital. In Malaysia, there's still a lot of places that is not accessible to primary PCI. Thrombolytic therapy is still a mainstay of treatment in some places. However, it did not get a good ST resolution. He was then referred to a tertiary center for rescue PCI done to the right coronary artery and subsequently referred to us for a stage angioplasty. Now, during the stage angioplasty, I restudied the RCA. I think the team there did an excellent job. The vessel is well reperfused, and you can hardly notice the stent. Okay. So on the right, on the left system, however, again, there is multivessel diseases. On the circumflex artery, we see a severe tight stenosis just before the bifurcation of the OM, and on the LAD, tight lesion, proximal LAD. So we proceed from this trial a physiology study of the circumflex artery. I know a lot of you might say that, hey, look, this is very critically stenosed. You do not need physiology, but it's still good to see, what does the physiology say? And sometimes you might be surprised that these lesions may turn out negative. But in this case, well, the RFR is 0.89, and we still proceed with a circumflex FFR, and it gave us a number of 0.76. Subsequently, we then proceed with a OCT guided PCI, and from OCT we can see sometimes we do OCT, we need to balloon it first, otherwise we're not able to get good flow. You can see here a thick fibrous lipidic plaque and not much calcification, so we do not need a lot of calcium modification technique here. We just need to POBA and then implant a stent, and that's exactly what we did. And one thing good about OCT is after the stent implantation, the AI actually immediately tells you stent expansion, and we see the white marker on the middle there. If everything turns out white and no red at all, then you can actually essentially close the case that this stent is well opposed and well expanded. There is a slight red dot there, which tells us there's a bifurcation, and that is why that area the stent is not fully opposed as read by the computer. And subsequently, after implantation of the stent, we remeasured the physiology. The RFR is 0.98 and the FFR is 0.99. Excellent job, well done, right? All right, for the LAD lesion, again, RFR already significant at 0.84. And we still, however, based on this study protocol, we will need to proceed with the FFR, and again, 0.7. So there is some, from this study, I also learned that for RFR is pretty much reliable. most of the time you will get a RFR that is significant. You will eventually get an FFR that is also significant. However, I would recommend that if your RFR is within 0.88 to 0.92, a borderline gray area, I would proceed with a full FFR study. And for this patient, again, this lesion, again, we did a OCT study, and again, it is a fibrolipidic plaque with some amount of calcification. I would not say it's a lot. So we did a scoring balloon and implanted a stent based on the OCT findings. And again here, because at the proximal end there's blood swelling, we are not able to get a full white bar, but the stent is well opposed, and there's no stent edge dissection. The stent is well expanded based on OCT. I think this is the best possible result that we can get. Again, after the implantation, we repeated the RFR, which is now 0.94, and the FFR 0.90. So in this situation, I think we have optimized the stent implantation based on imaging, based on physiology, to try to get the best possible outcome. So for this patient, we did a procedural time of 90 minutes with a contrast injection of only 100 mils. So sometimes people say that, OCT imaging takes up lots of contrast. If you know to limit your contrast injection, and you can even do a OCT imaging with saline injection, you are able to limit it to a very low number or very acceptable number, and the procedural time should also be very much reasonable.